I would like to introduce and welcome Dr. David Classen, who joins us from the University of Utah and is the CMIO of Pascal Metrics and serves on the Defense Health Board Advisory Committee. Welcome, Dr. Classen.
Thank you, and I know I'm the only thing between you and lunch, so I'll be quick as I can be. But we're going to talk about not only EHRs, but where this is all going with AI and how it will impact your practices as we move forward. So this is not just going to be another boring lecture about something we hate a lot, EHRs. We're going to go heavily into where AI is going in this space and how it may alter how we practice. So the focus here is going to be how health IT and AI can impact patient safety. And all of us as physicians were told quite a lot of stories about how EHRs would really improve patient safety when they were implemented. And based on my experience, and I bet yours, EHRs were frustrating and they failed to improve patient safety as advertised. So I'm going to start with some of the challenges EHRs faced and then talk about how we're dealing with that, especially in the world of AI. So here's a real case and a very sad case. EHR got implemented at a very famous health system in Chicago, very famous EHR. And a 27-year-old woman came in to be evaluated in the ER for severe lower abdominal pain. And she was fully evaluated in the ER and felt to have an acute abdomen and got taken to surgery. At surgery, she was found to be pregnant and the fetus did not survive. Now, how did this happen at such a famous hospital and such a famous EHR? What happened was there was a problem inserting an ultrasound report in her record from another patient. And so that other patient's ultrasound of the lower abdomen showed no signs of pregnancy and it was recent. And so the people taking care of this poor patient looked at that ultrasound, thought it was hers, and it was fairly recent, and said, well, she can't be pregnant based on those findings, and they took her to surgery. So a really horrible case. And this was not unusual in the early years of EHRs. As we were learning about them and to put them in, we saw a number of problems like this. Indeed, there was an article in JAMA that suggested that EHRs could actually facilitate patient harm rather than prevent it, which is what we were all sold when EHRs were put in place. And then there was an even more ominous study from a children's hospital in Pittsburgh where they put an EHR in and it actually increased mortality in their patient population. And what happened here is the EHR had all sorts of glitches that interfered with the rapid admission and ordering of interventions for babies and other young children. And this led to a measurable impact on increasing mortality in the hospital. So our early experience with EHRs was really not so wonderful. But this article is probably the most concerning. This article said, after all the hype of the automated hospital of the future, how good of a job will this do in preventing the most common medical complication in hospitals, which is medication safety problems? And so this hospital had it all. They had an EHR with computerized physician order entry. They had barcoding for medication administration. They had a robot in the pharmacy dispensing all the medications. They had nurse charting and pharmacist review. They had absolutely everything. So with absolutely everything, this group of investigators asked, gee, in this hospital of the future with all the IT in the world, I wonder how much harm we're causing to patients around medication safety issues. Half the patients were still being injured by medication safety problems. Why is that? Because a lot of the medication safety problems that we experience even today in inpatients can be prevented if we either don't order the medication, or if we do, we make sure the medication ordered is at the right dose, right duration, and doesn't interact with any other medications the patient's on. And what this hospital demonstrated is, even with all the IT gizmos you can imagine, they still weren't doing a good job of stopping common drug interactions, allergies, overdosing based on renal function, or even stopping a drug for a patient's diagnosis. So this is probably the most concerning, and this is how it's played out with EHRs. A lot of EHRs in practice, we think, well, of course they're picking up all these problems. Well, as we'll see, that's not the case. You guys probably didn't see this. This was a New York Times article that said our large community pharmacy systems are not doing all the medication checking that they used to. Why? Because the large pharmacy chains feel productivity of their pharmacists is more important than medication safety when it comes to dispensing. And why is this important? Because in the pre-EHR era, all the safety checks of medications went on at the community pharmacy. And not unexpectedly, most of us assumed they were playing that role. Well, here was a really interesting article in the Chicago Tribune. A group of reporters from the Chicago Tribune took prescriptions for Clarithrol and simvastatin to 255 pharmacies in the Chicagoland area. And they wanted to see these two drugs, which individually are fine, but together can cause fatal drug interactions. They wanted to see how many of the community pharmacies would dispense these two drugs together with no questions asked. Half the pharmacies dispensed it with no questions asked. Then, another 25% of the pharmacies basically dispensed it and told the patient there might be a drug interaction, but still did. Only 25% of the pharmacies in the Chicagoland area actually stopped the dispensing of these two drugs. Why was that? Once again, productivity on the part of pharmacy systems overrode medication safety. And you know, this still goes on today. I had a new blood pressure medication added to my regimen, and I went to pick it up at my pharmacy, and I said, "Did you check this for drug interactions with some other medications?" And the pharmacist said to me, "Oh yeah, the system does that automatically." So I said, "Humor me. Would you check?" So he did, and there popped up a drug interaction that the system had missed. So the safety net of community pharmacies, and you'll see in this article, CVS was the worst at picking up these safety problems. Why? Because they're the most aggressive about pharmacist productivity. So bottom line is, I think, despite all the hype about how medication, IT was going to improve medication safety, it really failed to. And so this got picked up in a report I was involved in at the Institute of Medicine, and basically made a series of recommendations saying, look, EHRs aren't delivering. Instead of preventing safety problems, they're actually causing safety problems. We made a whole series of recommendations, and as usual, most of them were not followed. No shock there. But one of them was, and this one is the one in red, and that basically said that the federal government's approach to these modern HIT systems, both EHRs and now AI, is to certify this software on the shelf and not worry about how it gets customized when it gets implemented. And unfortunately, that has become a real problem. And so at the Institute of Medicine, we said, you really have to go further than just certifying software on the shelf. You got to actually test it in operation, because we've learned the hard way that hospitals and clinics modify and customize the software as they implement it. So what is actually operational doesn't look like what's on the shelf. And this is really important in AI, as we're seeing big disasters in AI, because the FDA certifies it on the shelf, but what actually gets operationalized is quite different. So the same lesson we learned with the EHRs, we're now learning with AI. So basically, the government funded the creation of an EHR flight simulator, a system that would stress test EHRs for known safety defects to see if they could pick it up. And this system got rolled out nationally using actual cases where EHRs had harmed people. And so a huge library of these cases was used to create simulations to stress test operational EHRs. Here's an example of a patient, a real patient, that was admitted to the hospital for pneumonia and had her warfarin dose tripled. Nobody noticed, She had a bleed in her head and died. So this test that we're going to talk a little bit about has thousands of these real-world cases where the EHR either caused a patient to die or seriously injured them or failed to prevent serious injury. So long story short, when this system became operational nationally in 2009, there were some really disturbing results. Half of the hospitals that took this test couldn't prevent serious, fatal medication interactions included in the test. Things that if you prescribed a patient, they would routinely kill them. Half the time, couldn't pick it up. Now, if you talk to the administrators in those hospitals, they think they bought something that would pick absolutely every one of these problems up and stop it. Well, guess what else happens when you put these systems in? In the old days, we as docs would think hard about ordering a new medication in a patient, worry about all the interactions and everything else. Then, when the pharmacist reviewed it, they'd think, again, hard, second safety net. And then when the nurse reviewed it, a third safety net. They'd go through the same process. What do you think happens when you put an EHR in place? Everyone assumes the EHR system's doing the checking, and they don't have to. So we've seen case after case where a serious medication problem runs from the doc to the pharmacist to the nurse, and everyone assumes the EHR is checked for it. Well, this study really uncovered the fact that that's not occurring. And what was so interesting about this study, and this is just a graph of the individual EHR vendors. So each color is a different EHR vendor and how they performed on the test. And what you'll notice almost immediately is there's more variation within the same EHR than there is across EHRs. Why is that? Any guesses? It's all the customization at the local hospitals of the EHR products. There's more variation because of the customization of implementation within the same vendor than across. And that's exactly what the government missed. They weren't worried about what operational software looked like. They were worried about what it looked like on the shelf. We're doing exactly the same thing with AI right now. Exactly the same thing is happening. And the problem with AI is it's much more powerful and much more likely to convince a prescribing physician or ordering physician to trust it. Well, this is a study we published in JAMA that looked from 2009 to 2018 with this particular test. And basically, I think the bottom line here is that with this particular test, we did see some improvement in the performance of the test in the 30s to over 50 in terms of how hospitals across the country did. And there's this is thousands of hospitals that have taken this test. But still, almost 10 years later, half the hospitals were still missing a whole lot of medication safety problems. And you'd say, geez, you've been working on this for 20 years. What's wrong? Well, when you break out the kind of checks that EHRs do on medication safety, at the top line are what we call basic clinical decision support. That's checking for allergies, checking for drug interactions, checking for appropriate dosing. That improved a bit, but look at the bottom line. That's things like not giving a fetal fatal drug to a pregnant woman. We found that on average across the country that was only picked up 20% of the time. Not overdosing someone based on their renal function. Not following laboratory studies in terms of ordering a new medication or an existing medication. That hardly improved at all. And this is despite all the money putting into meaningful use, right? The whole point of meaningful use was to make the EHRs work better. Well, here's sort of a timeline of what happened. We spent an awful lot of money on meaningful use, and one could argue really didn't make much of a difference. And then, of course, the issue we physicians love is the usability of these systems. And this was an article we published in JAMA that tied problems with usability to the basic safety of the system. The more unusable the system was, the EHR was, the more unsafe it was. I'm sure for all of us, this is still a big issue, which is usability challenges. But now I think we have a fairly good idea that if it's a problem using it, it's probably a problem with safety of the system. So let's move into the AI world. First, a question for you all. If you look at inpatient safety, how often do you think inpatients suffer safety events in the hospital? Is it 1 in a million? Is it 1 in 10,000? 1 in 10? So how many people think it's 1 in 100,000 inpatient safety problems? Okay, nobody. Anybody think it's 1 in a million? Okay, how about 1 in 10,000? How about 1 in 100, 1 in 1,000? I see one hand over there, 2. How about 1 in 100? I see a couple hands. How about 1 in 10? That's where everybody's going, yeah. You're right, but that's because you all are heavily experienced in the system and you see all the problems, as I do, on a daily basis. And, there's been a lot of argument about this, that really, safety's highly reliable. You've probably heard the propaganda from the speakers on that. We're just like the airlines. We're just as reliable as they are, 1 in a million. And all the endless talks on high reliability. It's all crap. We're nowhere near the reliability of other high reliability industries. And if we needed any convincing, out comes an article in the New England Journal in January, this past January, showing that in 11 Harvard teaching hospitals, safety problems occurred 1 out of every 4 patients. Now that was the average across them. But if you looked at the largest Harvard teaching hospitals, Mass General and Brigham, it was close to 40% got injured during their hospitalization. Now some might say, oh well, this study needs to be repeated by others. It already has. This study used a similar methodology from a study done back in 2010, showed similar numbers. About 1/3 of patients in 3 household name hospitals, 1 in Boston, 1 in St. Louis, and 1 here in Utah, were harming patients at a rate about 1 in 3. And what was so concerning about that study was the fact that the major way these hospitals and most hospitals track the safety of their care is either through voluntary reporting, incident reporting, or through something Medicare requires, which is basically ICD-9 codes or ICD-10 codes about injuries. And if you look here, those 2 methods picked up less than 90% of the safety events. So the way we measure safety is awful. Now, that's about to change. This was a study in North Carolina published in the New England Journal, similar rates. This was Medicare doing studies in its populations, and look how high the rate is in nursing homes. No shock to anybody, I'm sure, but pretty high rates. Same methodology. The VA did it, same methodology. So the problem with this particular group of studies is they were done using manual chart review. And a group of us said, why don't we automate this in the EHR? And so that's what we did, make it easier. And so we automated it and found that you could make this work in Cerner and Epic and Allscripts and Meditech, and you could find safety problems at a level you were missing in the common volunteer reporting and administrative codes for Medicare. And when we showed these results to Medicare and said, look, why are you paying or forcing hospitals or doctors to report safety problems with a system that was developed 70 years ago, almost completely manual, and we all know missed most problems. So Medicare finally agreed that they would change this system, and they're in the midst of that now, and that will come back to haunt all of us. And Medicare has basically been moving its safety measures from volunteer reports and administrative codes to data taken right out of the EHR. They're called electronic clinical quality measures, and you'll hear more and more about them as we go forward. Medicare's goal is all the old quality measures that you chart abstraction are going away. In the future, everything's going to come out of the EHR for a variety of reasons, productivity, accuracy, et cetera. And Medicare has already developed measures in the EHR and mandated them. So this past year, Medicare started requiring safety measures around opioid reversal, hypoglycemia, and hyperglycemia, but they'll be rolling out 2 more of these measures every year for about the next 6. And then they're going to phase out their current measurement around voluntary reporting and adverse events. As this data gets released, probably in September, it's not going to look so good for hospitals. There are going to be very high rates when this comes out in September, and it's going to make the old Medicare reporting almost look fraudulent. So how will AI impact this? Well, this was a study published a couple years back where AI got applied to this idea of detecting safety problems in real time with data in the EHR. And a whole prospective surveillance system was built to measure safety problems. And the organization of that was very much like we do with infection control and infection prevention. I'm an ID doc and an infection control doc, and we automated measurement of HAIs, hospital-associated infections, 30 years ago. And we gave up voluntary reporting and everything else, and then we largely automated it within the last 15 years. But the rest of safety is like way behind. So this was a study that was done to show that you could do this with more than just HAIs. You could do this with a lot of different safety events, and you could do it in a way that you could pick these things up in real time when you could help the patient while they're still in the bed. Because most of our safety reporting is long after the episode has occurred. So basically what this system did was use a PSO, Patient Safety Organization, because everyone knew that it would markedly increase the detection of safety problems. Hospitals wanted legal protections, and that's why it was done through a PSO. And then make this work in all the leading EHR vendors across the country and show that you could move safety from a retrospective 70-year-old approach with RCAs and all the waste of time there into something where you could detect a safety problem while the patient's still in their bed and help them. And that's basically what's been going on for the last 10 years. And it turns out that we can make this work. With data from EHRs, we don't have to add anything new, no expensive new technology, so that we as physicians could be told, look, your patient may have this safety problem, what would you like to do about it? And find out it now, rather than find out it after the patient left the hospital and calls up and says, I have this urinary symptoms, and did you find anything in the hospital that might explain it? So I think this is going to be a big change, and AI is just going to push this faster. This basically, and we don't have to spend any time on this, how it works. Data gets pulled out of the EHR in real time, then gets run through AI algorithms and detects problems in real time, both for documentation and quality improvement and patient intervention. And one of the challenges in building this was there's so much noise in the EHRs about safety. How do you ever get through it? Because places that have tried to do this always get overwhelmed with so much noise they can't do anything or react to it. Turns out that AI can play a really big role here in cutting through all the noise of all the stuff in the EHR that might apply to safety and coming down with a very high positive predictive value that this patient's probably having a significant safety problem that needs to be addressed. So that's how AI is transforming this. We couldn't do this before AI. It just didn't work. So noisy. Nobody paid any attention to it. So AI is clearly changing it there. And when these new types of systems are compared to voluntary reporting, you can see that voluntary reporting picks up 147. These type of systems pick up 3,740. So this is a totally different ballgame. And once again, we wouldn't be able to do this without AI capabilities. In addition, several hospitals who've used these systems, detected safety problems in real time, and then intervened, have had marked decreased reduction in harm. The most harm reduction we've ever seen with any safety interventions of any type. So I think AI-enabled HIT is going to really fundamentally transform how we measure, detect, and manage safety as we go forward. And when you collect all this data, you can start creating AI predictive systems that can predict safety problems before they occur. This is a real patient, came into the hospital, had a safety predictor track them throughout each step in the hospital, and since this is a real case, all the dates are scrambled. Patient came in with a surgical problem, underwent surgery at the beginning here. Their safety score was a little elevated. It fell down, came down, stayed down for a long period of time. And then, as you can see, it began to rise again, and then you see those two dotted lines. One of those dotted lines was an intra-abdominal abscess, and the other was an intra-abdominal bleed. And basically, the safety predictive score picked this up more than 3 days before it happened. So now you begin to see in safety, we can actually predict these problems before they occur, where we can intervene and prevent them, because there's an awful lot of discussion about preventability. And most studies show you can only prevent 25 to 50% of safety problems. With this approach, you can prevent them all. So I think that's where we're going in this realm. And indeed, this sort of system could rearrange how we decide where to focus resources daily on an inpatient site. So here's a unit with everyone rated in this score, and you can see easily patients with high scores going up, patients with low scores going down. Gives you an idea where you might focus your efforts to prevent safety problems on a unit every shift. And then, of course, you can take this another direction, look at safety scores of all the patients on all the units in the hospital, and use that to guide where you drive staffing, where you drive prevention, et cetera. So this is already going on in several health systems in the United States, but I want to just give you a sense of where this can go. There's one other direction where this can go, which is, what if we were to give this information in real time to patients, families, and caregivers? So this was a project Robert Wood Johnson funded, basically where we took all that safety information you just showed you and created real-time dashboards for patients, families, and caregivers. And doesn't look like anything like what I showed you before. That's because patients designed this. And they designed this system so it would keep track predictively of how they're doing in the graph at the top and work across the continuum of care. And then it would show real-time safety problems or risks in language that patients could understand, give them questions to ask their care team about it, and then give them areas where they could get more information about that particular problem. So involving patients directly in their own care with respect to safety. And then we tested this in a large trial, but before we got there, patients told us, we just don't want this working on hospital computers. We want it to work on laptops, desktops. We want it to work on our iPhones. So we made it work in all of these areas. And the one feedback we got that patients were very unhappy about is we didn't make it work on Kindle. But an important point nonetheless. But you know, would patients use this? Oh, absolutely. We tested it in a very famous hospital, and we thought patients might ignore it. No, they or their family members were looking at this all the time. And of particular interest was family members at home looking at it on the iPhone to watch how their loved one was doing in the hospital. Really fascinating, the uptake. You know, without a whole lot of promotion or anything else, family members would watch this carefully day after day in inpatients. And then we studied it in terms of its impact. And basically, one of the things Robert Wood Johnson Foundation was really worried about was fear. So we tracked fear responses. They thought when you give this stuff to patients and families, they'd be scared to death. Not the case. Patients accepted it, thought it had good value, and got good usability scores. But of more important, the primary outcomes was patients who used this more often had a lower 30-day readmission and a lower 30-day mortality. The PAM score is just something Robert Wood Johnson does about patient engagement. But I think the bottom line is patients don't fear it, patients will use it, and patients can actually improve the safety of their care by doing so. So this is involved in clinical trials going on at several parts of the country, but I think this is something else that will be coming your way. So I'll finish with just a little bit about AI, artificial intelligence, and we can start with this little cartoon. And I think the bottom line is that there's so much hype around AI, you can't believe it. But there really is some meat there. But it's going to take a while to get there, especially in healthcare. It probably took 20 years in healthcare for the internet to be fully used. I think it may take another 20 years for AI to be fully used. So we're going to talk a little bit about what the success factors may be, but in healthcare, probably $100 billion has been invested in startups in AI. Across the broader economy of the United States, we're probably at about $400 billion invested in AI, so there's an enormous amount of investment going into these things. But a lot of the early AI companies are going under. And they're going under for reasons we'll outline as we go through this. So the first generation are probably not going to be very successful. Second, maybe a little bit more. I think it's going to be the third. If you're thinking about investing, it'll be successful. But I wouldn't invest in the first generation. So you see the little AI symbol here? Anybody guess what household device this is? It's taking over when it's gotten into a washer, right? So it's clearly having a huge impact in every industry on earth, and it will come to us. And these slides will all give them to you. You don't have to take any notes. But there are 3 different definitions of artificial intelligence. I like the one at the bottom. Artificial intelligence applies advanced analysis and logic-based techniques, including machine learning, to interpret events, support and automate decisions, and take actions. That's the one I think I like best. And I just want to show you where this is going in healthcare systems, hospitals and clinics and everything else. This is a survey done by a big health IT think tank called the Scottsdale Institute. They have about 65 of the biggest health systems in the United States. They've been surveying this for a while. Their survey done in 2021 found that less than 50% of health systems were actively involved in AI. Their new survey shows it's up to 84%. So 84% of health systems are implementing some form of AI. And here are the different areas that they're looking at. Here are the top categories. You can see them. They're around decision support. They're around business focus and around radiology. And this hasn't been published yet, but it will be soon. And so those are the major areas. You guys know that AI has been in radiology for 10 years. And as a radiologist told me, he said, I'm not worried about being replaced by AI because I use AI. But my colleagues, my radiology colleagues that aren't using AI are probably going to be replaced. I thought that was an interesting perspective, and it may apply to us more broadly. But radiology and imaging has been using AI for 10 years. But what's interesting here is the most used category are still the business use, readmissions, billing, everything else. So the insurance companies and the hospitals are more aggressively adopting AI around that than in any other area of healthcare. But a close second is clinical decision support and then imaging. And as you probably know, the drug companies are all over this because the drug companies have found that AI leads to drug discovery on an order of magnitude faster than anything they've had before. So drug companies are probably in all of healthcare invested the most, use it the most. I'd say insurance companies and administration hospitals are probably next, and I'd say the least use is probably clinical error, but that's going to change. As you've probably seen there, article after article published on how AI can improve productivity, how AI can help us manage our EHR inbox, how AI can help us manage communications with patients. It truly is going to take a while, going to fundamentally, I think, change how we focus on things. And this survey looked at health systems and large language models. You can see the 0 there. Nobody's not working on this. So in healthcare, everybody's working on how large language models can impact care. As you probably guess, it's going to go to productivity first, and already is. And many people are a little bit skeptical that this will give hospital administrators the ability to say, oh, I don't need to hire another doctor. We'll just use the AI assistant to do what that new doctor might do. So I think that's an issue that's coming forward. You can see on the right the areas that are being focused on AI right now. A lot of them are productivity focused, and that will probably continue. And then the barriers to incorporating AI, clearly I think we're already seeing this now with a number of small AI companies that are going under. They're having a really hard time developing acceptance by clinicians of the AI program recommendations, and they're having a hard time integrating this into workflow. In addition, I think regulation may play a role here, but not in the short term. But I think there's a lesson to be learned that we learned with EHRs and decision support that AI is going to have to learn as well. There's so much hype. You know, we get assaulted at the University of Utah by all these small little AI vendors that come in and say, oh, we got a great new fall prediction score, you know? And I say, we already have a fall prediction score. It may be manual, but it works. Oh, ours works so much better. And then when we go look at the technology and look at using our data in a pilot, we find out, guess what? It doesn't work much better than our manual fall risk predictor. And then we go a little bit further and we find out there are reliability problems, and we actually test it in our system because the AI small vendors don't know anything about software safety, quality assurance, or anything else. So I call them the garage vendors. A lot of these places are going to fail as they try to insert themselves in healthcare, even though they're getting huge money invested in them. We've had some companies that had hundreds of millions invested in them, and when their AI prediction model arrives and we test it, it fails. So I think we're going to see quite a development. But I do think there is a lesson to be learned from previous AI work done. And I think Google has been beaten up very badly in this space. Google developed a risk predictor for patients in the hospital developing acute kidney injury. They spent $25 million using the NHS database to try to predict which patients in the National Health System in England, which patients would develop acute kidney injury with data from their EHR. And after that 25 million, they came up with a score that the National Health System thought was so useless they never turned it on. So not to be stopped, Google then went to the VA in this country, spent another $25 million developing an updated predictor, and the VA looked at that predictor and said, not very useful. Then the VA, in 3 months, developed its own predictor that worked a lot better than Google's predictor, using the same data Google did. So there is this, I think, emerging view that criteria for success in the AI space requires one, good data, requires clinically driven analysis by domain experts. Because what Google was using is unsupervised learning, where they just went through massive data sets and had engineers who know nothing about healthcare trying to develop an acute kidney injury predictor. Didn't work. And you know, after 50 million, Google's now abandoned this. But just understand, 50 million is a drop in the bucket to the hundreds of billions that have been invested here. But I do think in healthcare, this is an important lesson. A lot of these, even big, huge companies are going to come rushing to us in healthcare and say, I got a great predictor. I think to be successful in healthcare, you have to go way beyond the predictor. So let me give you an example of this. This was a program we developed at LDS Hospital, an artificial intelligence program back in the 90s. And we could do this because we had our own homegrown EHR and we had our own homegrown clinical data warehouse. So we could pull all that data and create an AI program. And this AI program was to make the task of diagnosing, treating, and monitoring patients with infectious disease problems a whole lot easier. And I was working on the ID consult service at the hospital at that time, so I was aware of the challenges people had when they're trying to diagnose or treat infections. And so this was the first big AI application ever developed in healthcare. The first big study of AI application in healthcare was published in the New England Journal in 1998 as a special article. And I do think it has lessons for the AI vendors and for us as we go forward. First, we had to study it and its clinical impact. And so we did a large trial of this and showed it really improved patient outcomes. Decreased antibiotic use, targeted more effectively infections and diagnosed them, and then used appropriate therapy that didn't harm the patient. And so that was absolutely critical for us to get our clinicians, even though we, the ID consult service, developed it, to use it. We had to do an outcome study. Guess what the AI vendors are not doing right now? Outcome studies. Not doing them at all. And this is going to have to change, I think, if their AI applications are going to be widely accepted and adopted in healthcare. Indeed, one large EHR vendor rolled out a sepsis detection program that performed so badly they had to shut it down. So I think we're going to see more of that, but I think AI vendor comes to you and says, I want to use this at your hospital, you should demand an outcome study. You should say, look, I'm not going to just accept your area under the curve. I want to see an outcome study where this was actually studied clinically in the use of patients and you measured patient outcomes. Hardly any of this going on. And that's why I think a lot of these early vendors are going to die. They don't know anything about an outcome study and don't have the resources or the understanding to conduct one. Something else has to happen, I think, for these things to be adopted. They must go beyond prediction. So this is an old program. You're looking at a non-GUI screen. But basically, this was the program we built and developed at LDS Hospital. And what it did was bring everything related to infectious disease in a patient's record together on one screen. And you can see it's a very ugly screen, but the docs loved it because everything they needed to know to diagnose, treat, monitor infections is right here. And the reason that was so important to the docs is if they used this program, there were considerable time savings. We actually did time and motion studies to look at how long it took docs to make decisions with and without this screen. It took 15 minutes without the screen. What do you think it took with the screen and this program? 1 minute. That, I think, is another criteria for success in this space. You'd better save me some time, and a lot of it, if you want me to use it. And so that's one thing, a simple vendor who comes up with a fall prediction score, not saving me any time, and doesn't help me make a management decision or make a task run quicker. So I think that's going to be another big lesson learned as we go through the AI adoption in healthcare. You better give me more than just a risk score. You better save me time, and you better help my clinical decisions, and you better be able to prove it has an impact on patient outcomes. So I think that's where we're headed. And you could always understand the black box here. This is another issue. We would tell clinicians why the system made the recommendation it did. Guess what another problem in AI? It's a black box. You don't know why it suggested what it did. I'm going to argue if you want clinicians to accept these AI applications, you better be able to open up the black box and tell them why it made the recommendation it did. Then the other part of the program, the prediction part, we used all the data to help docs with initial empiric use of antibiotics in patients who might be infected, and we'd show them the leading cause of organisms by site, susceptibility information, everything else. But this is prediction with an action plan. It's not just a simple predictive score. I think AI vendors are going to have to get there. And then we had a lot of other screens that gave them more detailed information about drugs or infections. And then we gave them the ability to tell us why they didn't like the recommendation the system made. And that was heavily used early on. And that feedback led to improvement. So I think that's another thing AI vendors are going to have to do. And I will stop there and see if you have any questions. A lot to digest, I agree. Well, I can tell you the AI applications will be breaking down your door soon in healthcare. So take these slides, use them, they're all yours, and be skeptical. Be very skeptical. Thank you all.
That's a sign.